I'm sorry, I cannot pronounce that name. And his presentation is about the ultrasound guided transvaginal RFA of uterine. So now sorry, he graduated from the Champagnat High School in Italy, and now he graduated from the University of Genova in Italy, and now he's the I'm sorry, working in the diploma of the specialization of comparative psychotherapy, right? And also, and his research is using new much proceed with the research activity in diagnostic imaging in conventional radiology by using the new technology in the CT, ultrasound, and the fusion imaging. Okay, thank you. Please start your presentation.
Thank you very much. Good morning. Thank you for this inviting. I am Dr. Turtulici. I come from Italy. And I am director of the Department of Radiology, but my field of interest are all the treatment percutaneous by ultrasound. So that this is the field in which I explain my job. I start with the liver, the thyroid, the biopsy by fusion technique of the prostate, the ablation of the myoma, and I am a phlebologist, so I treat all the venous disease of the limbs. What myoma? Myoma is a benign gynecological tumors with high incidence. We have to think that between the age, the premenopausal age, the frequency is high, but the frequency grow up after 50 years age, over 70-80%. This is a pathology because if sometimes the 50% is not asymptomatic, it's good, but the rest percent are symptomatic, and the symptoms are very heavy because you can have abnormal uterine bleeding and possibly related anemia, pelvic pain, infertility, compression phenomena, dysfunction of reproductive sphere, a disorder related to the pregnancy. You use the FIGO classification, that is a classification of the gynecologist, in which you pay attention the position of the myoma, so that you start from 0 when the myoma is inside the uterine cavity until 7 when it's outside. This is important because you have to choose the best treatment according to the position of the myoma, not only the size. And this is a fusion with ultrasound transvaginal way. You can see that if the myoma is inside, it's better to make a hysteroscopy. No? Also when it is subserious. And when the myoma is outside, it is better to make a laparoscopy or a surgery, so that we can treat all the other myoma. For this reason, I divided is my classification, because I wanted to understand if it's possible to make treatment by transvaginal way. So I divide in the submucosa, intramucosa, and subserosa, that are the myoma that I can treat by transvaginal way. And then the pedunculate is outside, that it's better to send it to the surgery. The target is the reduction of the volume and the elimination of all the symptoms. So we can use a medical therapy, the traditional surgical therapy, myomectomy or hysterectomy, or the minimally invasive treatment, the treatment that I perform. And I prefer radiofrequency treatment ablation. Indication, all the symptomatic myoma, and the myoma that I can reach, because I use ultrasound scan. So there are a lot of approaches that I can use. The most important is transvaginal, but also the hysteroscopy, the laparoscopic, the hybrid, and also the transabdominal. That was the first approach that I made in the past. When the case is particularly difficult, I prefer to make MRI and make a fusion with ultrasound to understand the whole position of the myoma, because usually, if it's possible, you can treat not only one myoma, but a lot of myoma, until 4 or 5 for a patient in the same setting. This fusion you use usually for the diagnostic of the deep endometriosis. You can see MRA, it's better to see. So I can make a fusion, I can understand in ultrasound way what is the endometriosis. But sometimes for the planning of the treatment, I can make MRI. This is the setting. The room is a surgery room, in which there is an ultrasound scan. You use a transvaginal probe. The anesthesia is very important because we use a contour or spinal sedaction. Rare case, you use a general anesthesia. We can choose a lot of needle. It is very important because according to the size, the position, and the shape, I can change the needle. So there is a monopolar, bipolar, or this is very interesting because you can change the exposed tip. So I can change the exposed tip according to the myoma. You have to consider that if I have a 3 or 4 myoma, there is a myoma of 5 centimeters and another one of 1 centimeter, I can change the needle. So I can change the exposed tip during the treatment. And this is very easy to understand and very safety to do because we use a transvaginal. The gauge of the needle is from 15 until 17. It's better 16, I think, or 15 because sometimes the myoma is very stiffness is very hard. So if you have a good needle, it's easy to put the tip inside the myoma. And we can use a fixed or the moving shot technique, then I explain. This is some photo for a transvaginal approach. It's very easy. The most part of the myoma that I treat, I use a transvaginal. Then hysteroscopic approach sometimes. When the gynecologist make hysteroscopy, it's possible by hysteroscopic approach to treat the myoma near the serous, near the cavity. This is a laparoscopic approach. That is interesting for the myoma that are pedunculate outside the utero. And this is transabdominal approach. In a transabdominal approach, you use the fixed technique so that you can treat only some myoma, not all the myoma that are on the top in the front face. And it's possible to make a bleeding, that it's difficult to recognize bleeding transabdominal by scan ultrasound. And sometimes you cross peritoneal, so you damage intestine because there are around. You can lesion the parietal vessel of the wall of the abdomen. And also, if there is some infection, you can make infection intraperitoneal. But very important, very dangerous if the heat hit the intestine, because it's a very dangerous situation, this one. For this reason, I prefer, when possible, the transvaginal way. Fixed technique, you know, is the same of the ACC of the liver. You put the tip inside and wait 5 minutes and growing the ablation. But I prefer the moving shot technique that we have imported by Beck technique for the thyroid, yes? The procedure step is very easy. I have to visualize the myoma. I put the tip of the needle to the top, and then I start to make ablation, making a pullback. So you start from the top, slowly you come back, according to the exposed tips. This is, vediamo se riesco. Okay, you can see there is now, ecco, the tip is there, and then I start, wait, slowly I pull back. Then I change the line. In this way I can treat all the myoma. So the initial, you can see, was 3-4 centimeter, and after 15 minutes is very fast, and ablation time only 4 minutes. After 1 month, you have a reduction of 60%. After 6 months, 80%. And we know that after 3 years, also 90%. There are some complications. Yes, the minor complication is not important. It's pain, fever, is a stupid complication. But the minor complication can be very dangerous. The most important is the thermal injury to the organ, to the bowel. Then there is the perforation, but it's difficult to make perforation because by ultrasound you can check the tip of the needle. And the very interesting, it is very dangerous injury of iliac vessel, because if you make a damage of the iliac vessel intraperitoneal, it's difficult to stop the bleeding. But there are some difficulties because the position, sometimes the myoma is very far away. For this reason, I use also 30-35 millimeters of the length of the needle, is very far. You have always to see the tip of the needle because the ablation is around the tip of the needle, but you make gas bubble because it's a thermoablation. So then there is also the artifacts. For this reason, it's not so easy to be sure where is the tip of the needle. We are not in a thyroid that it's difficult, I know, not in the liver that it's easy because you are inside the liver, but you are intraperitoneal. So if the tip is in other place, you can make a damage around. So for this reason, sometimes when the case is very difficult, I prefer use of the virtual tracking. It is an instrument. Now all the ultrasound machine have this one, in which I put some magnetic on the probe, on the needle, and then I can see that the green line show me the needle, but the V tell me that there is the tip of the needle. So also if I can see the needle, I am sure that the tip of the needle is in this zone. Okay? This is the case. No? Yes, I can see the needle, but I am sure that the tip is there. This is a hybrid because the needle is outside, because the gynecologist uses laparoscopic, and I, by transvaginal way, check the tip. Using virtual, because the needle is in this position, and I know that the tip is there. So I can make the guide to the gynecologist to make a pullback, because the gynecologist, by laparoscopic, can see the tip, but I can check the tip. And sometimes I use also contrast enhancement in the difficult case when there are a lot of myomi, pre and post treatment, to understand if the ablation is a good ablation. Conclusion. I think that is a valid alternative to the treatment, traditional treatment, is a safe technique with a very few complications. The post-operative recovery is only 5-6 hours. In the night, the last part of the day, the patients go home. Is the surgery with a low cost, but very important for the fertility. It's not only for menopausal age women, but also for the young women. We have published some article, the first in 2018, then 2020. And the last one is a follow-up after 36 months. And we can see that we have performed over 100, yes, using all the technique. The most part is by transvaginal way. But it's very important that we have no minor complication using also the other instrument, the virtual navigator, for example, and with a good planning before to make treatment. But it's very interesting that after 3 years, 36 months, we reached 90% of reduction. Thank you very much for your attention.
Thank you very much for